You know, you can join AARP when you turn 40. I think that should be part of one of the diagnoses then. We all get, well, maybe I shouldn't be general, but osteoarthritis is their part of living, and I think it's part of the aging process of just doing things. Crystal-induced arthropathies, gout, pseudo-gout. And you may have seen in your years of experience people with a severe acute gout with a red, swollen, hot joint. Those hurt. And again, immobility, contractures, rheumatoid arthritis. Osteoporosis itself can cause bone pain. There's, you know, just pain in the bone hurts. And compression fractures, and fractures in general. Well, you fall, you stub your toe, you break your toe. That baby hurts. And so fibromyalgia, polymyalgia rheumatica, all of these things, bursitis, you know, where you hurt your bursitis for whatever reason, and then you try to move your shoulder and you're going, You know, some people self-medicate with things, but depending on how long it goes and how severe it is, you may need some other help with it. Oral pain, you know, dental, you know, cavity, infected gum, all of those things, dentures that don't fit very well, plain old cold, sore throat, nosebleeds, causes pain. You know, something in there is probably hurting. If you've had a dry nose in this area, we get dry nose, dry sinuses easily, all the time, especially in the wintertime when the humidity is down to less than 20%. So now we have a lot of humidity, so our nasal passages are nice and full, but that's what keeps the ENT people in business, is all the dry sinuses. Dry mouth. There's many medications cause a dry mouth, and disease processes cause dry mouth. And I have one right now. Let me take a sip. But so that is something that you can say, well, it's not really pain when you compare it to a headache, but it is not normal. The other one is dry lips, which goes along with the dry air and dry skin, and just making sure people have lip balm of some kind or another. And we all have our favorite. You know, and the coated tongue that people get from the dryness, and they're just not able to keep their mouth moist, and their tongue gets pretty, and you're going, I don't know how they can taste things. I don't know how they can, you know, they're just suffering through that. And so that, again, it's not, a pain like you'd expect from somebody with a broken bone, but it adds to some of the problems. And then the acute process. Surgery. We all know people who've had surgery have pain, right? But that can be from any kind of surgery, you know, whether it be laparoscopy for doing things, you know, that's probably the cause of the least amount of pain, but you still have some pain in there. Sprains, burns, trauma. Anybody who's been in a motor vehicle accident, been rear-ended, and you get the whiplash, that's very painful. And again, trying to get rid of that pain is pretty difficult. Okay. Everybody has a legal right for pain treatment. And that's one reason why we ask about pain. People do sue about not getting their pain treated, and they do win the lawsuits about not getting their pain treated. So that is why it's very important to ask about the pain and ask about what is making it worse, what makes it better, how did it start, what's going on with it, and the location, and have them describe it. So we need to, again, use those pain scales that you can print off. You can print off, but I probably could with some help. So treatment of pain. The treatment of pain has been described by the World Health Organization, and this has been around for a long time, and they go through some basic steps. And usually it goes in a step-ladder case, if you've ever seen the drawing, where you start off with simple medication. You usually try your Tylenol, your acetaminophen, your nonsteroidals, and you go use those and see how they are. You may use some topicals, different sort of topical medications. Your nonsteroidals come as topical, some other things. Your lidocaine patches, although those are difficult to get through your Medicare D, which in the elderly have Medicare D, and they have very strict guidelines. Antidepressants are an adjuvant therapy for pain medication. And now I was watching TV the other night, and there's one of the antidepressants that has an indication per FDA for treating pain. So something that we've known forever, for many years, now has been approved for the FDA. Using your seizure medications to help with pain. With general pain, it helps as an adjuvant therapy. And depending on where you are, what the severity of the pain, what the origin of the pain is, if somebody's having a post-op pain, you're probably not going to start with acetaminophen and a nonsteroidal. You're going to go to bigger guns. You're probably going to go to a narcotic of some kind, and you can add your adjuvant therapy to that, depending on the severity of the pain, the location, etc. So you're going to be using all of these things together. And you may need some muscle relaxants in with that pain, which helps, again, is a part of the neuropathic thing. If somebody has a neuropathic pain, like one of the radiculopathies, the peripheral neuropathies, those other things, you're going to need a whole gamut of pain medicine to help treat that. You're going to need your anti-epileptic drugs, you're going to need your antidepressants, you're going to need your narcotics to go with that. And when you're treating the pain, we need to monitor. We can't just say, we're going to give this and then not evaluate anymore. We need to evaluate and know the length of time that the medications work. Give it a couple of days, see what goes on, and then maybe modify the pain medication. So we need to be checking on that and modifying it and making sure that we have the pain controlled. When you're treating pain, this is an end-of-life issue, but one thing is a person who has, say, metastatic cancer in their process of dying, an issue discussed with the family is, and with the patient is, what level of pain control do you want? Do you want to be having pain control? You're never going to get it down to 0. But can it be tolerable if you're obtunded? Do you want a drip where you're put to sleep? How much pain control do you want? Do you want to be able to talk with your family? Families many times say, well, I want to be able to talk with my loved one. I don't, and we're going, okay, let's step back. We're looking, you're not going to be able to talk with them if they have pain. People with severe pain can't talk. They can't think clearly. So then you have to say, okay, what are we going to be able to compromise on here? Part of pain treatment is just being there. Pain is always worse at night because people are alone at night, or they think they're alone at night, and many times people are. And so pain gets worse. They don't have anything else to distract them. So pain is always worse at night. And so just being there, your presence, your touch. You've learned that years ago in school. It's the basic touch. Comforting music makes a big difference. Again, that's part of the distraction. Talking. The chaplain helping with some of the spiritual things. As people maybe reliving it, that they had, this is the same pain as their parent had, their mother or father or their grandparent. And so they saw that person go through it, and they think that they're going to have to be suffering the same as that person. Not true. We can make some differences here. So, and remembering that pain is always multifactorial. It's very rarely, if you have a broken finger, usually that's probably one factor, but there's also other things in there. The tendons, the nail health, all these other things add to it. And if it's your pointing finger, you may be in big trouble because how are you going to handle, point at things? But again, if it's your dominant hand, you may not be able to write, you may not be able to do things. And so again, that adds to the pain and it adds to the anxiety related to that. Support, exercises is very important. That's what they tell us. So, range of motion, keeping that joint working so you don't have so much muscle spasm and stuff helps with that. If you have a headache, many headaches are worsened because as your headache, you stiffen your neck muscles. And so using things to loosen up those neck muscles, which really helps with headaches. And I shouldn't say most, but many people, by the end of the day, their shoulders are up like this and their neck is so because of dealing with the tension. And then you have your tension headache. And so just trying to work with that and helping people to relax and moving with that. Repositioning, relaxation techniques, all help with treating with the pain. Okay. Now we're going to switch over to suffering, which sometimes it's hard to define pain from suffering. But they are two different things. If you're looking at suffering, oops, I lost my note. You're looking at other issues. One of them is psychological. Again, we're going through the same realm that we went with pain. Psychological suffering is loss of identity, loss of who they are, loss of independence. People who all of a sudden they can't drive. That's loss of independence. That's part of suffering. And people who are known just for their disease process and not for themselves. It's a person with a cancer, a person with a heart failure. I think we've evolved from that, where now we're talking about the individual and not just the heart failure person and these other things. We're able to describe them as a little old lady with glasses in a wheelchair. I'm going, okay. So, and so we need to be looking at people as the individuals and remembering who they are. People say that, they're not able to do their usual tasks. They may not be able to do what they used to be able to do. That helped to identify them. The things that they used to do for, to keep them, for their pastimes, their hobbies. They may not be able to play the piano anymore. They may not be able to embroider, to sew, to cook. And so that's part of their identity, part of that independence. Grief, many of the elderly go through huge grief because of that loss of identity and independence, but their family members are gone. Many of them say, my only social outing are the funerals. And so, because their friends are all dying, their family members are all dying. And so, again, they go through that grief process. Every time you go to a funeral, no matter what it is, it brings back those memories of previous funerals and previous losses. And the other one is just the recurrence of their disease process. People with heart failure, they're always on the verge, and they may get it under control. They go out to a family outing, and they have ham, potato salad, dill pickles. And if you've ever made those things or looked at the salt content, you know that then when they get done with having this fun with the family, their heart failure is going to be worse. And so they may have to stay to the hospital. They go out for the family for the 4th of July, and on July 6th they're in the hospital. And so again, recurrence of their disease processes, not just of cancer, but of the other things that are part of living with that disease. Anxiety, depression. Again, it is a suffering, it's not a pain, but it's a part of a disease process. And one of the basic questions you can ask is, what is your biggest fear related to your pain, related to your loss of independence, related to? And sometimes that just allows a person to open up and just say, somebody is going to listen to me, and it may just help with their suffering. Other ones are end-of-life issues. We went through some of the things early on about people having pain and suffering that they think it's going to be the end of their life because it's the major disease process. And one of a nice statement to say related to end-of-life issues and people having a severe pain or severe problem, say with cancer, say with significant osteoporosis, and they've already had 3 or 4 broken bones, what is important things for you to achieve in your life? What would make life worth living for you? That's the end of life. That's some of the psychological, spiritual issues. The burden to the family. Families are important here, whether there aren't any family, whether the family is distant, whether the family is close by. The communication with the family, what is the family feeling about this person having this chronic illness? And I'm generalizing from pain and suffering to a chronic illness. I know I've sort of moved on. But these are chronic illnesses. They're usually related to getting elderly. So in the disease process, some people don't understand what that disease process is. The only thing they've known is that somebody else had it, and they know how that person went. They know that their father had it. I had a person who I just diagnosed with diabetes, and he broke down in the office because his father had diabetes, ended up with an amputation, and he was sure he was going to have an amputation within a few years. And he was just diagnosed. And so going through all of that, what does that disease mean to you? How is that going to add to your suffering? And having people understand the medical jargon, no matter how easy it is for us to try to say it in layman's terms, how easy it is for people to look up on the computer and gather information, watch TV and learn all sorts of information on the different programs, like ER and these other ones where they learn a lot of stuff. But what do they understand about the disease process and the words that we're using? Congestive heart failure. What does that mean to that person? It's like trying to describe what the pain is, what the suffering is. Social parts of suffering includes finances. The cost of the medications is severe. Some of these people have to choose even with Medicare D,